Good morning, everybody, and thank you for joining the Injury Prevention Plus Safe Environment for Every Kid, or SEEK, program action period call number 1. We are in wave 6 of SEEK, and we are very happy to have all of you. Thank you always to our program partner, the Ohio Department of Health, the Violence and Injury Prevention Section, or VIPS. So welcome everybody today. We will get started with hearing from Dr. Henenhan and Dr. Bolden. They come to us from Southern Ohio, and they were participants in wave 5 and 6 of our SEEK program. They're going to give you a little preview of what they worked on during their experience with SEEK the first time, and then maybe what they're working on currently. And then we'll hear from Zainab with the data review. And then we have our expert today, Dr. Gaw, on cannabis safety and your child. And then if we have time, the QI corner. So welcome everybody, and I want to thank all of you for the hard work you have been putting in for SEEK. I appreciate very much that there was a lot asked of you during the holiday season, and getting through all of that has been very much appreciated. I know all of you have been working very hard on this. You got your pre-work surveys in, thank you. You got your baseline data in, thank you so much. So please know that you are appreciated, and moving forward with the hard work that you have done and will continue to do. And in the chat, if you could please share your name and your practice name so we know who was on the call. And then Dr. Henenhan, Dr. Bolden, I have your slides and ready.
Sure. Okay. Want to thank you for the opportunity to discuss SEEK and its impact in our practice here in Southern Ohio. My partner, Dr. Bolden, and I, she works in Victorville and I'm in Ironton. So we're spread out across the county. We both work for the Ironton Family Practice Family Medical Center, which is part of the Community Action Organization, which was started here in 1969. We are part of the Health Resource Services Administration. We see all patients, all insurance, and we have a sliding scale for those that have inability to pay. We currently serve over about 40,000 in our tri-state area, which includes Southern Ohio, Eastern Kentucky, and Western West Virginia. We have 8 locations in Lawrence County, Ohio. We provide medical and dental, as well as behavioral health, the WIC office, housing, school-based medicine, just to name a few of the things that we do. Dr. Bolden and I have worked together over 15 years in Kentucky, and in 2020, when our hospital closed, we started working for family medical centers. And we've been involved multiple times in different service programs, including flu clinics, health fairs, bicycle safety camps, just to name a few safety oriented things that we've done. We had done about a year ago, we did the atopic dermatitis through the Ohio AAP. And when that was finished, Brooke reached out to us and said, hey, we have this program called SEEK, and it was the SEEK 5 program. And so we both signed up for it and did it, and that we found out that, it really had a lot of benefits for the patients in our population. The slide is the tangible resources, our safety tools, furniture anchors, cabinet locks, things like that, that are so expensive. And now patients, we're very appreciative that, we gave this to them for free, as a lot of our population has decreased socioeconomic services. Then the next slide is all the handouts, and the talking points are so beneficial that you can use not only in your well visits, but in that sick visit, if something should come up there, it's very versatile. It's not only for just your well visits, but I've found myself handing out different handouts for different situations. And the second thing that was really nice for us was the ease of using the iPad. You hand it to the patient, and tell them, first I always ask them, hey, I'm doing this program, it's safety. There's no repercussions. You don't have to pay for anything, and you might actually get some benefit out of it, being a parent. And so I'm going to just talk about, because I know there's some things that Brooke wanted me to work in today, is the ease of using the iPad. Was so much better for data collection because you don't have to spend evenings filling out paperwork or doing anything and then sending it all in. And it just made it so much easier. So Donna and I both have one nurse. Right now I'm up to two, but at the time I did this, we both had one nurse. So we ended up doing everything ourselves. And so I would introduce the SEEK program. If they, consented, I gave them the iPad, say, hey, there's some questions here if you want to just answer them, and then I'll come back and then, collect the data and things like that. And then I just move on with my, rest of my well visit talk and, things like that. And then when I would come back to talk about like immunizations or, doing a lead level or something like that, then I was able to go back, review very quickly what was, what they had written in their iPad remarks. And then I could pull out the appropriate handouts because I had already pulled out a 9-month well, if it was a 9-month or something like that, to already hand out to them, whether they actually did the program or not. So basically all of my wells got a handout for at least their development and safety issues and things like that. And so that was, a good thing for us. And then afterwards, then I would go back and, finish up in my office and things like that. And then either the nurse would bring me back the iPad or I would take the iPad, go back into the room and pick up the iPad so that I could finish out everything. The other thing that was very helpful for us was that it gave us our Mach 4 points. And so we all strive to, keep up with everything. And so it just kind of like, did two things for us for the same price, basically, of doing, spending that time. So I have a couple of stories. If you'll go to the next slide, is the sleep sack is where I have, I introduce, as I'm talking, because a lot of these things are, already in our well visit and our anticipatory guidance. And so, I show them the sleep sack and I show them, what goes on. And I usually hand it to the dads. And I said, this is for you. I know you're really stressed out. You have a lot of things that are going on in your life and adjustments and stuff, but this is really easy directions. And then of course on the back it says, this side up. And so it starts them talking and laughing and, decreases their anxiety about that first visit, coming in with a newborn. Another one with the sleep sack is I had a family and they don't have a lot of support. And so I'm handing them the sleep sack and the mom started crying and I was kind of like, oh, okay, it's not that big of a deal. But to her it was because she had a sister who was 3 months old who died of SIDS when she was a little girl. And that meant a lot to her. So I don't think we always know what impact we're going to have on our patients. And then the next slide. But if you can help prevent injury or harm to any of your patients, then the 25 Mach points don't matter, but that life does. So that's all I had to say. I don't know if Donna, do you have anything to add on that?
No, really the only thing that I would add is that my nurse and I made folders based on age and we put the handouts in it. So
Yes.
it's easy for us just to hand out a folder with all the handouts in, and then they can look at it whenever they have the time.
Yes, I have the same thing. I have a big accordion folder and actually it's at my feet right now. And that's what I use as well.
Ours are
And if you,
actually like individualized folders. So I hand out the entire folder to the
oh, okay.
families. Yeah.
That's a good idea. And you brought it home with the real life examples. I remember us talking about those in the last wave, and how you knew it was important for your patient population to be exposed to this program, but then your day-to-day kind of wins really kind of nailed it for you. So thank you for bringing the real-time examples in and sharing your experience so far and how you kind of incorporated it into the workflow. Thank you both.
Welcome.
Appreciate it. Okay. Zainab, I can stop sharing for data review.
Thanks, Brooke. I'm going to share my screen right now. Can you see my screen?
Loading. Okay.
Okay. Okay. So when I share my screen, everyone comes up on the side. But anyway, let's try to make this a slideshow. Okay. So again, like Brooke said, thank you all for taking the time to submit all of this baseline data, especially during the holiday season. We really do appreciate that. We've mentioned before the importance of baseline data. It's just to give you kind of an idea of where you stand as a practice. Um, with implementing this new screening tool or this new QI data collection tool that we'll be providing, it kind of gives you an idea of how you're performing before and how, and if there are any areas of opportunity, areas of improvement that you can work on. We understand that it might be a little bit difficult or time consuming. And thank you, Dr. Bolden and Dr. Heenan, for giving us a brief overview of how it was for you during the last wave. I'm glad that it was a pleasant experience. But again, this data just shows how you stand now and how, again, where your areas of opportunity are in terms of improvement, in terms of where you can focus a little bit of more of your time and effort. So all the data that we're going to be showing today is baseline aggregates for everybody that had submitted their data until now. Again, we don't have any practices that haven't submitted their data. So again, thank you everybody for taking the time to put that in. And so you can see in the data collection tool for both baseline and QI, we have 5 umbrella topics, and you can see those as the headers for each of these slides. And then we're looking at whether or not those patients were screened for any of those needs, and if they indicated that they had a need for any of those topics, if they were counseled. Um, I'm only going to talk about baseline as we move through, move through the program and we enter like the QI months. There'll be a little bit of additional information that we'll be sharing. But just for baseline, there were some practices that had some screening in there. We did see some practices that provided counseling, but not necessarily a screening. So you might not have had a screening in place, but if the patient did indicate a need, then there was counseling provided based on that. So we are hovering in terms of screening for social needs at about 30, the higher 30s, lower 40s in terms of screening. For counseling, again, counseling is also taking into account patients that had needs that they mentioned to their provider that they had counseling on, but not necessarily had a screening. So that's something that I want everyone to keep in mind. But for the younger age group, it looks like we had higher screening between 50 and 40%. For the older age group, the 13 months to 5 years, we do see a little bit of lower numbers. However, do not be discouraged. Again, this is just baseline. Uh, this is what you had available in your electronic record. So this could be as accurate or as missing as whoever inputted that data had input that data. Our next topic is family needs. So this is anything like if the mom is struggling or if the primary caretaker is struggling, if the mom has any maternal depression or anything like that. So questions like that are included in family needs. Again, screening for this for both age groups is hovering at about 30 to 40%, which isn't bad. And again, counseling here is a little bit more evened out for both age groups again at 30, higher 30s, lower 40s in terms of counseling. Home safety, this is our biggest topic out of all of the topics, both in QI and when we were collecting baseline. This includes questions like if there if there's been CPR training for the primary care taker at the home, if there are smoke detectors, if furniture is secured safely to the wall and stuff like that. So all of these home safety questions include, or all of those are included within the home safety topic. Again, screening it is pretty good, considering that all of those are included again within home safety. So we have about in the 40s, low 50s, low 30s here for both age groups, birth to 12 months and 13 months to 5 years. Counseling is a little bit more messy, again, because we we are considering counseling in terms of overall counseling. So they don't have to have, again, they don't have to have been screened to be able to be counseled. So the patient could have mentioned a need during the visit and you could have counseled them. So I'm assuming is how everyone understood the baseline collection tool. And again, once we have our individual meetings with you as a practice, we can have another of these discussions to see if your data looks good to you, if we have a misunderstanding in terms of how you understood the data or understood the data collection tool and how we meant for it to be understood. So again, that could be discussed in our individual data calls. Car seat safety, actually, a lot of practices look like they already have some sort of screening in place. You can see that these are very high compared to the first three, the home safety, um, the family needs, and the safety needs. So we have screening rates at about 80%, 70% for both age groups, and a lot of those people look like to have been counseled. So again, counseling rates are at about 60, 50s to 60% for both age groups. We're going to see a similar trend for safe sleep. A lot of again, this topic is only asked for of the younger age group, that birth to 12 months. A lot of those patients have already been screened, so I'm assuming that a lot of practices already have some sort of question or some sort of screening in place that ask about safe sleep, and if the child has a safe place to sleep. And again, any of those people that indicated a need, we're seeing high counseling rates or pretty high counseling rates compared to the other area topics. And finally, resources provided. So if there are any types of resources at your practice, any resources on how to install car seats safely, where to get CPR training or anything like that, all of those are included in these resources. We had a few practices that had Bright Futures resource sheets. Um, so those are all considered in terms of any resources that you provided to to the family. So we have a high percent of resources provided. Again, the resources that we're providing as the AAP for the QI months include resources for all of the other area topics that we just discussed. So you're going to see these numbers increase. I know, again, like I said, as we continue through QI months and as we have other action period calls, we'll really encourage you to provide that resource sheet to all of the patients that you see, even if they do not indicate that there is a specific need for any of the topics that we just looked at or just discussed. Once you provide that resource sheet to them, then they'll have that information readily available. If they were in a hurry or didn't feel comfortable, I guess, talking about any of their needs, then they'll still have those resources available to them in case they want to take a look, or in case they have a need that comes up later after their visit. So this is the data and what it looks like for baseline. Again, when we have our individual meetings with the practices, you'll see slides very similar to these, but specific only to your practice, so that the lines in the data will look different just depending on how your practice performs. during baseline. If no one has any questions, that's the end of the data that I have ready for today. If any questions do come up, again, like I said, we'll discuss individual level data with each of the practices. But I can hand it back over to Brooke um, if no one has any questions.
Zainab, thank you. Yeah, any questions that could benefit the group before we kind of get on the individual practice coaching calls around data? And like Zainab said, any emails that come in around data, I can ask her and then get you an answer back. So any of those means of asking questions works.
Yes.
Okay. Hearing none, we will move forward. Zainab, thank you so much.
Thank you.
Okay, Dr. Gah, I have you up next. Welcome in and thank you.
Yeah, thank you all for having me. I'm going to pull up my slides here. 1 second. All right, and then you guys can see my slides.
Looks good. Thank you.
Awesome. All right, so hold on 1 second. All right, so thank you again for having me. So my name is Chris Gah. I'm one of our pediatric emergency medicine physicians here at Nationwide Children's Hospital, and I also have a dual appointment in our Center for Injury Research and Policy here, which is part of our research institute. And I have had a long-standing passion for injury prevention and poison prevention, even though I do oftentimes see injuries after they happen. So I appreciate all of your guys' efforts throughout our community, keeping our kids safe. Today, I'm going to be talking about cannabis, especially in light of issue 2 passing in 2023 and gradually being implemented over the past year to year and a half and so. And so this talk is titled Changing Laws, Changing Risk, and How Cannabis Regulation Has Child Safety Implications. So I have nothing to disclose. And the way I structured this talk is to kind of go through 3 major areas. And the first is really to describe how and why cannabis products pose a poisoning risk to youth, and specifically why that is becoming more pertinent and more of an issue in today's world. The second part is a little bit of a dive into history. So Ohio is not the first state to legalize either medical or recreational cannabis. And so there have been other states before us. And so we'll take a look at some of the data that other states have generated and some of the data nationally to really describe how this changing policy landscape is really affecting our children. And then the third is the action part. So what are the opportunities and what are the challenges that make those opportunities a little bit harder to prevent cannabis poisonings in youth? And what can we do as individual providers and practitioners? And also what can we do as advocates, as a group of pediatricians and public health practitioners? So before diving into all of this, I just want to review some big picture 10,000-foot view definitions real quick. And the reason why is because we hear so many different terms being used in the media, being used by policymakers, and even by medical practitioners. So you hear cannabis, you hear marijuana, you hear Delta-9, Delta-8, THC acetate, THC isomers. And so there are so many different terms, and they actually have subtle differences in meaning. And those subtle differences in meaning not only impact the risk to a child, but also how it's regulated at the state level and the federal level. And so I just want to remind everyone, so when we talk about cannabis in its purest definitional form actually refers to the plant. So people, when they're saying cannabis, are usually referring to cannabis sativa, cannabis indica, cannabis ruderalis, so all of these different types or strains of cannabis plants. And within the cannabis plant, there are hundreds of compounds. There's probably greater than 400 compounds that have been currently cataloged, and we actually don't know what many of them do. But the 2 that are the focus of medical interest and national interest are CBD and THC. So CBD is typically not considered psychoactive, and it's known to have some neuroprotective effects and anxiolytic effects, and is used in certain types of FDA-approved medications. So there are a couple out there that use CBD. But what the public is usually thinking about is THC, which is the psychoactive component or compound within cannabis. And there are different types of THC. So Delta 9 is the most commonly referred to, but there are isomers or analogs of that, including Delta 8 and THC acetate. For the purposes of this talk, we're really going to be focusing on THC versus CBD because that's really where the poisoning risk to children comes in. And we're really focusing on Delta 9 as opposed to the isomers of Delta 9, mainly because of a loophole in regulation. So the issue 2 law, or the issue 2 that passed and the legislation that followed, really focuses on Delta 9 regulation, but we'll touch on what that means implication-wise on the other cannabis isomers. And so I'm also going to focus on a subset of cannabis products because there are so many different types of products out there. There are tinctures, there are concentrates, there are vaping and smoking products, there's the plant itself, but really a lot of this talk is really going to focus on edible cannabis or cannabis edibles, which at the crux of it are basically food or drink products with cannabis extract that can be THC or CBD, but really we're going to be focusing on cannabis products, cannabis edibles that have THC, because again, it's that psychoactive component that poses a potential risk to children. All right, so let's do a little dive into history. And so before Ohio decided to enact Issue 2 and pass Issue 2 as a ballot initiative, there was already a wave of a changing product and policy landscape ongoing over the past couple of decades. And so the first thing I want to point out is that there's been an increase in THC potency that has been increasing risk to the population. And when I mean THC potency, I'm going to use perhaps a little bit of a corny saying, but the weed of today is not the weed or the marijuana of the 1970s. And in the 1970s, the THC potency within a cannabis plant was around 2 to 4%. And what we've seen, however, is the THC potency within a cannabis plant has nearly tripled over the past couple of decades. So it was around, this is a graph showing confiscated, so these are all technically illegal products, confiscated plants by the DEA from 1995 to 2014. And you can see that the THC percentage in the plants being confiscated has gone up from 4% to up to 12 to 13% in 2014. And so this is again referring just to the plants. There are many products that have way higher potencies that are technically legal. And for example, a lot of THC containing oils can have up to 30 to 40% THC and be considered legal and regulated. When looking at edibles, I just want to highlight how potent edibles can be. And so this is a chart provided by Leafly.com, which provides guidance to adult users who are interested in edible products. And you can see that this chart kind of describes different THC doses of an edible and what effects that you would be expecting. And so ideally, the way that the chart's set up is that you're supposed to be aiming for some sort of dose, usually within the microdose to moderate or microdose to high category, which is that first left-hand part of the column. But you can also ingest acute and macro doses, which are up to 50 to 100 milligrams or 100 to 500 milligrams. And so I point out this, which is considered a macro dose, and there's a little bit of a warning attached to that, what to expect, that this is an intensely intoxicating dose, and many people experience adverse effects. And I want you to keep that in mind because I'm going to advance the slide and show you this product. So this is actually a product available in New Jersey, which are THC containing lozenges. And so that one package that you can buy contains 10 gummies. Each gummy has 10 milligrams within it. So the package of 10 gummies has 100 milligrams of THC. And so that one package that you're receiving already has a macro dose, and one gummy is already a moderate dose. And these are, again, adult recommended doses. So this has nothing to do with what, not that a child or adolescent should be ingesting these, but obviously because children are smaller and weigh less, they can have even more acute doses or more acute effects at lower doses. And a lot of these, it just speaks to the potency of even each individual serving size, let alone the package itself. And so this Verano product is regulated. And what I'm going to show you is that amidst the regulated market, we've been seeing an unregulated shadow or gray market also emerging in a lot of these states as cannabis has exploded in popularity. And so I'm going to show you a picture of this, which is a package of Nerds ropes at first look. But if you look closely, you'll see the word medicated in green up above. And you'll see that there is a marking of 600 milligrams of THC. So this one rope, which is hard to partition because it comes as a rope, in this package has 600 milligrams of THC. So this is technically an illegal or unregulated product. And you can see that oftentimes these products can have even hyper concentrated or hyper potent doses above what is legally regulated in most marketplaces. And the authors of this study had looked at almost 730 unregulated cannabis products and had determined that the mean THC content in the packages that they looked at was 460 milligrams per package. So again, way, way above what is a recommended serving size and way, way, way above what has been described as a macro dose, which was already described as having potentially adverse effects. And again, a lot of these are shaped like food products and candy. And so it can be hard for portion control for an adult, let alone a child, especially a child who doesn't know that these products can be dangerous. And so we talked about the increasing potency of products, but there's also increasing availability across the country. And I'm going to show this slightly out of date graph in the sense that it stopped in 2022, but I think it does a wonderful job of illustrating how our nation is viewing and responding to shifting consumer and citizen values with respect to cannabis. So back in 1995, it was medical cannabis was technically illegal. Recreational cannabis was technically illegal. It's a Schedule I drug at the federal level. And then throughout the 1990s and 2000s, there was a wave of medical marijuana legalization, followed by a second wave in the 2010s of non-medical or recreational cannabis legalization. And you can see that that wave has now covered over half of the states in our country. And then Ohio joined that group in 2023. And so currently most states in the country have some sort of regulated cannabis program. It's a mix of medical, non-medical, or both. And very, very few states have restrictions on cannabis at this point. And we have also joined that group. So I'm going to shift gears a little bit and then talk about the risk. So I've talked about, and I've mentioned a couple of times that there's a risk to children with these increasing potency and increasing availability of these products. And I just want to highlight some of the clinical effects of cannabis. And another phrase that I've heard some of our toxicologists and poison center specialists describe when they talk about this wave of cannabis and marijuana legalization is that it's leading to what they say is not always a high that you want. And what they mean by that is obviously the psychoactive effects of THC is desirable and what people are aiming for in adult users and sometimes in adolescent users. But at those macro dose levels and at the levels where people overshoot what they're aiming for in terms of the ideal psychoactive effects, you can get cannabis intoxication or cannabis poisoning, and it's easier because the products are more potent. And as a pediatric emergency medicine physician, we see this not only in our teenage population, but especially among young children who come in with altered mental status, coma, vital sign changes like hypertension or tachycardia, vomiting, seizures, or changes in their breathing patterns, sometimes with respiratory insufficiency and sometimes with apnea. And it can be scary to the parents. It's definitely scary to us that we are starting to see it so commonly that we are prepared for it. But it really speaks to how potentially dangerous and how profound the clinical effects of this substance can be, especially on young children. And people have looked into how much can lead to some of these profound effects. And so there was an article that came out that looked at hospital data and tried to really characterize what is severe toxicity, some of the effects that I listed in the last slide, and what is prolonged toxicity, which they defined as greater than 6 hours of symptoms, and how much THC is actually needed to lead to those effects among children less than 6. And so this group, led by Dr. Pepin, looked at basically several years of hospital charts. And for those of you thinking back to your med school days, did a receiver operating curve and really calculated the following, which I just want to highlight. 1.7 milligrams per kilogram was the average dose that could lead to prolonged toxicity, again, symptoms greater than 6 hours, and 2.3 milligrams per kilogram could lead to severe toxicity, some of those effects on that prior slide. And so, again, for a little bit of context, you think about a one-year-old's approximately 10 kilograms, give or take. So we're talking about a child who may have ingested maybe 2 to 3 gummies, 10 milligram gummies. And so it's not a lot in terms of how we conceptualize it as a food product, but it is a lot in terms of the dose that is contained within these cannabis products and cannabis edibles. So let's take a look at the state data that started to come out in the 2010s. And what does that have in terms of implications for us in Ohio? And so state data provided us an early warning of what was to come. And so in the 2010s, and specifically in 2012, the state of Washington and the state of Colorado were the first 2 states to legalize non-medical cannabis use or adult cannabis use. And so Colorado has really paved the way in the epidemiology and the monitoring and surveillance of the effects of this policy. And researchers in Colorado had kind of in their early studies really kept a close eye on how many people were calling poison control centers, how many people or how many children were coming into the ED. And so again, this graph demonstrates unintentional marijuana exposures among children 0 to 9. So it involves cannabis edibles, but any cannabis product. And you can see that after legalization in 2012, that those numbers steadily increased in the years thereafter. Again, this is just a single site and it's just at Colorado Children's, but you can see that there's an abrupt shift that is temporally related to that policy change. Kind of zooming outwards, it's not just ED visits, it's not just calls to poison centers, but it's also more serious cases leading to hospitalization. And so other researchers have looked at trends over time using FIS data, which basically pulls hospital data from multiple states, over 25 or 26 states. And they demonstrated that there's over a 13-fold increase in marijuana-related exposures among children less than 6 between 2004 and 2018. But again, if you look at how this graph is curving upwards, you're really seeing that increase around that mid-2010s. And that mid-2010 period is when a lot of states, that second wave of non-medical cannabis legalization was occurring. And these are not just hospitalizations or admissions to a regular floor bed. We see that about 50% were admitted inpatient, but that about 15% were admitted to an ICU, or NICU, and 4% of patients within this cohort required mechanical ventilation, so intubation and ventilation to support their breathing. And more recent data has really just suggested that this trend is continuing. And so these are Poison Center call data for children under 6 years of age, and the number of calls being placed to poison centers across the country has truly exponentially increased. So this number has increased almost 1,400% between 2017 and 2021. And about a quarter, so 23% of these exposure calls ended up being admitted to hospitals around the country. So this is definitely becoming a larger national problem, and it has been following the trend of non-medical cannabis legalization. And our local Central Ohio Poison Center here is seeing a mirroring of that trend over the past year since our legalization here in Ohio. I'll touch briefly on cannabis in adolescents and young adults because a lot of the focus on risk is on young children, just because the doses that kids can accidentally ingest can be so high. But there is some data also emerging that this can have an impact on our older children and our adolescents, especially as they transition into young adulthood. And most of this data is still focused on medical. And so this study really highlights one complication of more subacute to chronic cannabis use, which is cannabinoid hyperemesis syndrome. And this is a study done in Massachusetts. And they really demonstrated that what you can see is that pre-legalization compared to post-legalization, that the length of inpatient stay has increased for cannabinoid hyperemesis syndrome. The number of days of antiemetics required has increased. And then even the fact that some patients needed ICU level care. Again, this is just one hospital, and a lot of the data that we're starting to get is coming from different hospitals in different states as we start to put things together. But the physicians on this study really hypothesized that the increasing potency of the products that people are using are leading to more severe symptoms. And this could explain some of the data that they're seeing. I'm just going to touch on this because this remains an area of controversy. So please remember that there's still work to be done in this area. But there's a lot of talk about cannabis and mental health associations and whether cannabis use can cause certain mental health conditions such as acute psychoses or other mental health disorders among adolescents and children. And I think the jury is still out on that, though there's a lot of work in this area. I'm presenting this study to demonstrate that there is some mixed data here. And so this looked specifically at the United Kingdom and looking at users of high potency cannabis and their mental health outcomes over time. And they were able to identify that high potency cannabis users appeared to have anxiety disorder and cannabis use problems when they adjusted for sex, socioeconomic status, mental health, and frequency of use, but they weren't really able to see an effect in some of those other more common but concerning mental health disorders. So again, the data remains mixed and the jury is still out, but it's something to keep an eye on and something to think about, especially as we begin to field questions from our patients and parents and guardians about the effects of use over the long term. And, you know, there's attempts to really try to understand from the young adult literature and the adult literature, are there any health outcomes? So I presented some mixed data on mental health in young adults and adolescents. And this group attempted to look at everything that's been out there since 2023. And really the only thing that they can really definitively describe is a positive correlation between cannabis legality and cannabis use, which they think is mainly due to access. But they weren't really able to comment much on any other major associations. So again, I think as we learn more and as we see more use and understand the effects of that use, we'll be able to comment more and really provide guidance for our patients. All right, so what's the takeaway? So I think the takeaway is that there is increasing risk for our pediatric population. And these factors, legality, potency, accessibility, and acceptability of cannabis products is really feeding into the risk. And right now, what we know is that risk is really concentrated among young children, and we don't really have a good understanding of the risk to adolescents and young adults yet. So really the risk that we can talk about more concretely is the risk of poisonings to young children and how to keep young children safe. And so what can we do as pediatricians and public health practitioners? I think this is challenging. And so the main challenge, and I'm going to start with the glass half empty and we'll go into the glass half full, is that policy remains in the hands of the states. So Ohio passed an Ohio law in 2023 after we had our ballot initiative. But across the country, every state had their own ballot initiative and every legislature enacted their own version of the law as they saw fit. And so there's immense heterogeneity in terms of how cannabis is regulated among states, how it's packaged, what is expected, who does enforcement, everything that you can imagine, there's just variability, and that leads to massive confusion. And the laws are constantly shifting and changing, which leads to additional confusion. And the fact that certain products, such as THC-9, are really what is being regulated, but other products like THC-8 are oftentimes regulated by different laws. So again, this mishmash is making it very challenging to understand for consumers, let alone providers within each individual state. Cannabis also remains a Schedule I drug at the federal level. And so though the federal level is not technically enforcing or superseding states at this time, there's that tension of the fact that there is conflicting laws between states and our federal government. And so what does this end up looking like? Well, I'll show you that, you know, these were 5 states, and these were some of the first that had enacted recreational cannabis laws. And I'll just even point out the THC serving sizes. There's some variability in what is a serving and how much can go in a package. Even if you scan across, there are differences in restrictions and product approvals. And so this can be immensely confusing to, quite honestly, everyone involved in the process. There's also the packaging portion of this, where warning labels differ greatly between states. And some labels don't, I'll give you an example, Michigan doesn't really look like a warning label at all. And so I think that this also adds to confusion and ambiguity, especially for consumers who are trying to discern, is this product a THC or cannabis containing product, this CBD containing product, or is this a product that's just a normal food item, especially if they are inadvertently mixed together. There's the challenge of just human norms of, is one gummy really a serving size for any of us? Yet 10 milligrams is almost a moderate dose, low level and moderate dose according to that website. So can we as adults stop at one? And would a child, and I think we kind of know the answer, would a child stop at one if they thought it was candy and they had access to it? So I think these are some of the challenges that we're facing. And again, the norm is that these products are accepted and that these products are desired within our greater community, in the sense that, again, all of the cannabis laws, especially the non-medical or recreational cannabis laws, were passed by popular ballot initiative. So this is a wave of a popular request of sorts to have these products in our communities. And then there is the unfortunate parallel unregulated marketplace, which remains challenging to enforce. and oftentimes creates more dangerous products or product lookalikes, which are even harder to discern from the regulated marketplace and from other food products. So again, these are some of the challenges that we're facing as we counsel parents and as we advocate for them from a policy perspective. So in the last few minutes, I just want to highlight some opportunities. So I think we have opportunities to educate the public, whether that's in the office or broadly as advocates, of really trying to avoid buying edible cannabis products if young children are in the home. It's just very hard, especially the way that these edibles are packaged, even the regulated products, especially if they're out of packaging, to tell them apart from food products and popular food products that children like. So oftentimes avoiding the cannabis product, if at all possible, is really the best way to reduce risk. Treating cannabis like other medications is an opportunity to talk about safe storage. So we talk about lock boxes for potentially dangerous medications, and cannabis can be treated like a medication, even though we often conceptually consider it for non-medical use. But I think that we can reiterate that there are risks to young children, and so being able to kind of mitigate that risk through safe storage is an opportunity to help families keep children safe. And the third is, I think, a evolving process, because cannabis, unfortunately, still remains stigmatized in many different ways throughout our communities, even though acceptability is increasing. And I think there's a lot of apprehension about talking about cannabis openly. I think that discussing with family and friends in an open, honest manner, ways to keep the home environment safe can really start to shift the cultural attitude towards talking about cannabis, similar to how we talk about other safety topics. And so I think that this is something that will take time and something that we can all model for our families. Because I think that this is one of the biggest barriers for some of our patients and families, is feeling safe talking about this product. And then from a policy perspective, some of these products don't meet Poison Prevention Packaging Act compliant packaging. Most of, if not all of these products are not placed in unit dose packaging. So, you open the bag and 10 gummies are available to you. As opposed to kind of single serving packaging. We saw some of the warning labels and we saw how appealing some of these products can be. And so that's an opportunity to improve at the policy level. And then enhanced enforcement of the marketplace, which I think is a challenge from a state perspective as well as a federal perspective, of how do we integrate and respect the laws that have been passed, but also be able to regulate that shadow marketplace that is creating parallel products that could be dangerous. So with that, I will stop sharing and open it up for questions.
Dr. Goff, thank you so much. Really good information. Yeah, any questions from the group in the chat, or you can unmute. And I'm curious to hear if you've seen an increase in this issue with your patients and families.
Yeah, so we were talking, I think all of our emergency medicine providers have seen at least one case, including our trainees. And we've all talked about it. It feels anecdotally that there's more. And our Poison Center has also put out a couple of press releases over the past year describing the increase in the number of calls they're receiving. So this definitely is having an impact. It's a tangible impact. Before coming to Columbus, I was in Philadelphia when New Jersey had enacted their law. And Philadelphia is right across the bridge from New Jersey. And we saw it there too. Like there was just suddenly, you felt like you were seeing it more than once a week, whereas before it was maybe once a month. And so this is becoming a more common occurrence. And I think it just speaks to how prevalent these products are and how available they are in our communities.
Yeah, that border state impact is real, right?
Mm-hmm.
Do you have reading materials to provide patients and families? We have given resources via a website, but is there maybe more to share?
So we have on Nationwide Children's website a couple of infograms and informational sheets about marijuana and cannabis. And then I'm doing some math here, last year in 2024, 2023 into 2024, the Trainees for Child Injury Prevention, which is the joint American Academy of Pediatrics program, had done basically a day of advocacy around cannabis edibles. And so there are a lot of free resources that both infograms as well as tip sheets that are available as well, that kind of touched on some of the things that I highlighted on some of the last couple slides.
Great, thank you. I will share that out to the group.
And then just, I will share with you, Brooke, to share with the group that the laws in Ohio are about to change yet again, or potentially change again. There are 4 separate House bills in various stages of moving through our legislature that are attempting to change the cannabis regulations, not to add an additional level of confusion or uncertainty. But I'll share that tip sheet so you understand what the current law regulates and what is being proposed. And then I'll share a tip sheet made by OSU, our OSU Law College, which really just distills the legislation down into a very digestible Q&A, because the actual legislation is not digestible at all.
Thank you. Appreciate that. And good luck to the State House doing all of that. Is the PDF of the chart with the doses of THC and how it affects people at different doses available?
So that came from a publicly available website online. It's not scientific. It is what one cannabis dispensary had decided were different levels of high, as for a lack of a better way to put it. So that was, if that's the multicolor chart going from like 0 to 500, that if that's the one you're referring to, that is available on leafly.com unless the URL changed. For the children, for children under 6, that was studied and published in Pediatrics. And I think I can find that paper describing like what the milligram per kilogram dose is that we started to see either prolonged or severe effects in children. And so that's specifically for children under 6 from edibles.
Wow, that's impactful. It doesn't take much.
Mm-hmm.
Wow. Okay. Yeah, the candies are confusing and dangerous is kind of a follow-up comment in the chat. Wow, thank you so much. If you have any further questions that you aren't asking today, please email me and we can get with Dr. Goff for more information. But I just wanted to kind of wrap things up with QI Corner. Dr. Goff, thank you so much.
Yeah, thanks everyone.
Very nice to meet you. Okay, hopefully you're seeing the QI Corner slide. So just real quick. We've had some good questions come in, kind of overall working through the challenges and the bugs of program implementation, which is typical, and we appreciate you asking. But specifically around program implementation workflow, again, kind of at the beginning of things, especially through the holidays, there's a lot to ask to getting on board with the program. So just to kind of overview on the workflow and kind of add to what Dr. Pearl shared at the beginning, review the Seek screening tool, kind of get familiar with it, what questions and what fields are going to pop up when kind of throughout the process. This is one of those programs, and we've said this before, that once you start doing it over and over and over, it'll become more familiar. But because we're at the beginning, we may not be fully familiar with kind of the flow of it. So reviewing it is a good idea, and then reviewing your current workflow around well visits and analyzing where you can fit in the screening tool or the resources. Can you make folders? Can you make kind of a wall hanger based on patient's age? But can the caregivers start the screening tool maybe in the waiting room or in the exam room to kind of get a jump start on the screening tool, and then you can kind of jump right in with the counseling pieces. And then the practice staff, certainly looping them in to the program. Can they help you? Are there nurses available, MAs, social workers, community health workers? There's passion around this work, and we want to get everyone involved. And then engaging staff for ideas and modifications. Ask them about what your PDSA should look like or what tweaks to your PDSA you can do. And then eventually you'll have best practices around completing the screening tool and getting the counseling and caregiver appointment survey in time. So maybe not right now you'll have the best practices, but that is kind of the end goal for feeling more comfortable about a workflow and then implementing the program. So I will send this out in an email, but real quick, next steps. If you haven't done so already, if you could schedule your practice coaching call with Zainab and myself. Work on your first PDSA worksheet. What has program implementation look like for you? Kind of get that down on paper so we can talk about it. And then at the end of January will be the monthly patient totals for all of your patients seen for well visits 5 years old and younger. That number will be due, and I'll be emailing about this. And if you need additional iPads, there are some available. If this will help with your flow of the program, I can mail those out. Just let me know specifics, what provider and what practice needs those. And then I have added the county level resources to the SEEK resource page. If you use a resource locally that you don't see posted for your county, please let me know and I'm happy to add that. And then we just want to keep in mind kind of the big goal of what all this hard work is for. So we want to help our patients and their caregivers. And then the means to do that is kind of using the tools of the screening tool, counseling, and then the resource share. So I appreciate that there's some challenges at the beginning, but if we keep our communication open and talk through how we can best support each other, we can get through this, I promise. So thank you everybody for joining today. I appreciate your time and again, your hard work with this program. And I look forward to talking with you soon. Have a good week. Thank you.